Hello, and welcome back to my Fireside Chat series. In this set of videos, I want to discuss outcome measures, and they are used throughout all of healthcare and throughout all of clinical psychology, everywhere except in the family courts. And outcome measures of the child's symptoms are incredibly useful and incredibly important. So I want to introduce that idea into the family courts and encourage people to start collecting outcome measures, ratings of the child's relationship behavior and relationship quality with the targeted parent, because we want to see improvements on that. We want to fix that thing. And a treatment plan should include four elements: uh, identified goals, but goals identified in measurable ways, because we're going to measure it with the outcome measure. So, measurable goals. Then, interventions specified for each goal. So, for each goal, how are we going to accomplish that? Then, estimated time frames for each one of those interventions and each one of those goals. How long do we think it's going to take to reach that goal? We might have benchmarks along the way. We expect this, and this all the way up to the final goal. And then outcome measures to monitor the progress in treatment and also to identify when we've achieved the goal and can stop the treatment. And so, with all treatments, we want the same structure and we want outcome measures to monitor treatment progress and treatment success. If you think about healthcare, you think about going into your physician, they do a set of tests. They say, "Oh, you have this diagnosis. Here's the treatment for that." They treat you for a little bit and they say, "Come back in 6 weeks," and they do another series of tests to see if you've gotten better. The second set of tests are the outcome measures to see if the treatment's been effective. There are only two causes of ineffective treatment, by the way. Either A, you've misdiagnosed the pathology and you're treating cancer with insulin, or B, you've accurately diagnosed what the pathology is, but you're not competent in delivering the intervention for that pathology. Because if you've accurately diagnosed the pathology and you're competent in delivering the intervention, then things will be fixed. So, what we want to do with outcome measures is we want to start monitoring the symptoms that we're looking to increase or decrease or whatever effect we want to have. We need to start monitoring that. And we'd like to see some movement in at least 2 weeks. 2 weeks is good, and then about 6 weeks, though, we want to begin to see significant movement. And if we're not seeing significant movement on whatever symptom profile we got for ADHD or autism or school behavior problems or attachment pathology, if in 6 weeks, if we're not seeing some movement, then we need to go back and look, have we properly diagnosed the pathology or accurately diagnosed it? Is there something else getting in the way of this? It's called a barrier to treatment. So what's going on? Have we accurately diagnosed what the pathology is? And are our interventions appropriate for the nature of the pathology? And so that's one of the importance of outcome measures, is simply to monitor the treatment progress. Now, in clinical psychology, uh, outcome measures are used throughout clinical psychology. So something like ADHD, we might actually use structured assessment instruments like a child behavior checklist or a Connors rating scale. But more often than not, we simply, as clinical psychologists, develop our own sort of informal symptom rating scale, informal, informally rating scale. The most common one is called a subjective units of distress scale. That's called a SUDS. And it's easy, it's simple. It's just a 1 to 10 scale. 1 is low and 10 is high. So you go into your physician and you say, "Doctor, this kind of hurts." The physician says, "On a scale of 1 to 10, how bad is your pain?" That's a subjective units of distress scale. 1 is no pain, 10 is excruciating pain. And we can do that about anything. So if I'm doing marital therapy and the couple comes in that week and I say, "So over the past week, on a scale of 1 to 10, how frequent have you guys been fighting? And see, my wife says, I think it's a 7. The husband says, I think it's a 4. And so there's differences of perception. And that's one of the elements of this rating type of rating. It's not really an assessment of anything, it's just a way of structuring the collection of symptom information. So the pathology is going to lie about everything I do. It's coming up with this idea that I've come up with this rating scale, these assessment protocol. What's the reliability and validity? There's no reliability and validity to these things. You go into your physician. It says, how bad's your pain on a 1 to 10 scale? There's no reliability. He just wants to get like an idea of how bad your pain is. And that's the same thing we're doing. Now, the subjective units of distress scale, that's a 1 to 10, used often over in the medicine healthcare stuff. In psychology, and you can use any set of numbers. There's 1 to 3, 1 to 5, 1 to 4, and each one has strengths and weaknesses associated with 1 to 10. 1 to 7 is commonly used, and it's called a Likert scale, a 1 to 7 scale, with 1 being real low on something or real bad on something, 7 being real high or real wonderful. 4 is right dead center, normal range, and then like a 3's somewhat, 5 is highly, extremely, not at all. And so there's kind of rough anchor points for Likert scale. And we use Likert scales for pretty much everything. So if I wanted to sort of formally measure a child's disruptive behavior in the classroom, I might ask the teacher to just give me a rating in mid-morning, lunchtime, and end of school on the child's disruptive behavior. And we define that somehow. What the child's getting out of the chair or talking out in class, those sorts of things. And we put it on a Likert scale. So, 1 is not at all, 7 is extreme, and where was the child during your day? And that's just a way of collecting symptom information. It's not an assessment. It's used within an assessment. We want to collect the symptom information. It's just a way of structuring our collection of symptom information. And we're going to start with wherever we are, and we're going to improve the things we want to improve and decrease the things we want to decrease. And we're going to pay attention and make sure that's happening. So with this family court pathology, I came over here. I have not seen, in 10 years, I have not seen anybody use an outcome measure over here. And that's because their treatment is absolutely unsuccessful. They have no idea what they're doing. They are incompetent. They are solving nothing, fixing nothing. And so there's no outcome measures because their treatment success is 0. And so that's a significant problem. So I'm bringing back standards of practice, clinical psychology standards of practice. We abide by the ethics code as clinical psychologists. Forensic psychologists don't. And so, as clinical psychologists come back, we will be bringing back professional standards of practice, like a treatment plan, like outcome measures, and estimated time frames, and informed consent, things that are standard professional practice in healthcare. So when I started to develop the instruments over here, because you just have awful psychologists. So I developed the diagnostic assessment protocol. That's the diagnostic checklist for pathogenic parenting, and the parenting practices rating scale. You use both of those together, you will absolutely 100% of the time be able to diagnose the pathology, because those are the symptoms that we need to identify. Are they present or absent? If they're absent, then it's something else. If they're present, then there's only one possible explanation. So let's document whether those symptoms, 3 diagnostic indicators, and balanced by the parenting practices rating scale for the targeted parent, are those symptoms present? But in addition to that, we're going to be moving over into treatment. And so I thought I would also generate for you the outcome measure for that. because that's what we do as clinical psychologists. That's what I do. I'm real experienced with it. And so, and it's necessary, it's needed over here for both um, monitoring treatment progress, but it's also very going to be very useful in the actual therapy itself, the family therapy. So I thought I would describe for you in this set of videos here what exactly I propose as that or recommend that be used as an outcome measure in the family courts. And essentially, what I did was I came up with um, three items. Now, you'll see four items there. I'll talk about four later, but it's basically three items rating on a 1 to 7 scale. The items are affection, cooperation, social involvement. So the first one there is a child's attitude, hostile to pleasant. I didn't use the word affection. I just kind of said attitude. Are you hostile? That's a 1 or a 2, or are you affectionate, cooperative, 3 and 4? Or affectionate, cooperative is a different rating. Um, and these are rated by the targeted parent on a daily basis. One of the things that does is it corrects the inverted hierarchy in the family. So we have a cross generational coalition and an inverted hierarchy where the child's judging the parent as if the parent were the child and the child were the parent. It's an inverted hierarchy, Mnuchin. Excuse me. And so, what this does right away by having the targeted parent rate the child on these three symptom features is it puts the parent back in charge of judging the child, which is the proper hierarchy within the family. Um, and so, affection, it monitors the attachment networks. That's one of the prime networks we want to see movement on. We want to move this child from being hostile and aggressive to actually having a normal range bonded relationship with the parent. Now, normal range is 3, 4, 5. So actually, we don't want like high ratings of 6 and 7 all the time because that's like not normal. A child shouldn't be attending and taking care of a parent like that. That might be a role reversal relationship. Pops up there every now and then, that's fine. But we don't want it up there all the time. Cooperation monitors the emotional regulation networks. And we'll talk more about this, but it monitors the emotional regulation networks. When the child gets angry, frustrated, anxious, sad, whatever, those emotions lock them up and they're not able to be cooperative. Notice I'm not saying obedient or compliant. It's cooperative. We want that flexibility and their participation in what. Now, again, normal range 3, 4, 5. Kids are, we have to go in and prompt them a couple times and things. And 6 and 7 is, oh my goodness, the child's going out of their way. You don't even have to ask them. Then the third rating is the social involvement, because I don't want the kid coming over and just sort of being superficial, but then go hiding in their room. We want them coming out, participating in the family. And again, we want normal range 3, 4, 5. And so every day, the targeted parent would rate the child on those three items and email those three numbers to the family therapist. I'm recommending a dialectic behavior therapist adapted to the family courts. So this would be the outcome measure that would be being sent in from the targeted parent every day, three numbers. That's it, just three numbers. You don't have to describe what happened, just three numbers to the family therapist. The therapist would then put those into an Excel file, and we could begin to track the child's progress. And that's going to have important implications when we talk about protective separations and restoring the child and monitoring the child and monitoring for relapse when we get recovery. So all this, so we want to start collecting that information into an Excel file. So that's the basic idea of an outcome measure. So let's move over to the next video segment, and I'll discuss this outcome measure more specifically um, about what the ratings are and how to go about doing this, and then we'll move into how to use it within treatment. So this is not just monitoring the treatment progress; it's actually a valuable tool that will be used in the therapy and in the stabilization of the child after the protective separation period. So with that, follow me over to the next one, and we'll talk more about the outcome measure here.